Hello, my name is Sarah Wade, and my client case presentation is about the importance of considering a client's capability for change in adult females with ADHD, where I have reported two cases. So, what is ADHD? ADHD is a complex neurodevelopmental disorder that affects approximately 1.2 million Australians. There's a rising prevalence in females, and it's categorized into three main types. So there's hyperactive and impulsive, inattentive, or a combination type, which is a combination of those two. First line treatment is stimulant medication, but that can come with some hefty side effects like nausea, appetite loss, sleep problems, and mood changes, which can be less than desirable for people. So we're seeing a rise in people reaching out for alternate therapies, and nutritional management strategies include minimizing additives, minimizing processed grains and sugars, correcting nutritional deficiencies, repairing the gastrointestinal tract, testing for underlying contributors like cryptopyrroles, heavy metals, methylation problems, pathogens, and more. So, what is capability? Capability can be described as possessing the appropriate skills or knowledge to perform a desired behavior, and can be further broken down into subcategories of knowledge, skills, memory, attention, decision making, and behavioral regulation. So, how does this relate to ADHD? When we are looking at the categories of capability, and we can also look at executive functioning, they're quite similar. In ADHD, people are at a higher risk of executive functioning problems, which is known as executive dysfunction, which can present as reduced memory, reduced attention, and reduced self regulation abilities. Therefore, because these are so similar to capability, you can therefore potentially lower a person's capability for behavioural change. So, this case study was inspired by two female clients who were diagnosed with ADHD but had distinctly different presentations and difference in approximated capability of change. So let's explore that. Client one was a 37-year-old female. She came into clinic for assistance with her ADHD symptoms, in particular focus and attention. She was really proactive. She wanted to reduce the impact of ADHD on her life and minimise the need for long-term medication. Client two was a 35-year-old female, and she came in for assistance with her ADHD symptoms and her inability to function day to day. She tried medications, often forgetting to take the medication, and that medication made a minimal effect with a minimal reduction in symptoms. She wants to be able to function day to day and also wanted some answers as to why her ADHD was so bad. When we compare these two cases, we can see that the ADHD type was the same. They were both diagnosed with a combination type ADHD of hyperactive and inattentive, but when they presented in clinic, it was quite different. I looked at the clinical symptoms as client one being hyperactive and inattentive, whereas client two seemed to display more of the inattentive symptoms. To be able to approximate the capability of these clients, because there was no clinical tool established that I could find, I have used an approximation. So what I've done is I've gathered the information from their files in WellNation that is applicable to me approximating their capability. So I looked at their ability to take medications and supplements, their appetite, what their family independence were like, what type of work they did and the demand of work, and also the support that they had around them. So client two, as you can see, had the ability to take medication and supplements, a really good appetite, no dependence, relying on her. She was a FIFO receptionist and didn't have any support, but also didn't really show the need for support. I've approximated those as adequate indications of adequate capability. Client two forgot to take medication. She could only identify a really small window of time at night that she'd be able to take supplementation because she had a small window of routine. She had nausea in the morning, which impaired her ability to eat. She had a partner and three really young kids that were completely reliant on her. She was a nurse 3 days a week, and she has a partner that helps, but only sometimes. So that I've approximated those factors as a low capability of making behavioural change. I also noted significant clinical observations that helped to lead me towards the approximation of their capability. So client 1 was enthusiastic, asking proactive questions, taking notes. She was motivated and gave a lot of input. Whereas client 2 had a low demeanour. She had 3 young children, often requiring attention throughout that telehealth consultation. She lost her train of thought a lot. She had a poor memory and poor motivation. The treatment for these 2 clients were similar in that we wanted to increase the nutrients for neurotransmitter production. In client 1, the treatment plan looked like multiple dietary changes with the supplementation and lifestyle changes. Client 2, we had few dietary changes, a supplementation, and a priority to complete testing of a hair mineral analysis and some stool testing that had been issued by an integrated GP, but she kept forgetting to do them. So when I was establishing the treatment plans, with client 1, I used a standard EM pitch and I used education to inspire to motivate this client. And we found success at her return visit 3 weeks later from all of the factors in the treatment plan. With client 2, I approached the treatment plan establishment completely differently. So we focused mainly on identifying the barriers that were going to impair her from being able to make these behavioural changes. And we discussed support to be able to combat the barriers. So for this client, it looked like things like setting reminders to have meals, setting reminders to be able to have the supplementation, asking for support and help from the people around her, like her partner, to be able to help to remind her to take her medication or help with the grocery shopping. Also reaching out to a hairdresser to be able to actually extract the hair samples for her to be able to send off the hair mineral analysis test. And I checked in with her a couple of times to also just remind her about that stool sample. And we had success for most of the treatment plan points at the 6-week return visit, which was really amazing. So when we look at the evidence out there and different capability questionnaires that exist, there are quite a few out there. A lot of them use the capability approach, which is a complex theory, and that's used as the base to be able to evaluate individuals' capabilities. But these questionnaires have all been established based on a particular condition, age bracket, location. They've been made for a reason. So they weren't appropriate to use in this specific situation that I was wanting. I've also looked at the behavioural change model called the Combe-B model. And what this is, it analyses 3 different factors: capability, opportunity, and motivation. And the belief is that these factors work together to be able to facilitate behavioural change in someone. And if there's a lack in one or more of these, then we can identify the barriers and put together strategies to be able to facilitate and improve the behavioural change. There are multiple studies that have used this framework in healthcare to be able to improve adherence to treatment plans or interventions that have had success. So why should we establish a clinical tool? If we can identify capability in these clients, identify the barriers, we can come up with support strategies to combat the barriers, which will in turn help us to provide a treatment plan that's in line with their capability. It'll increase the treatment plan adherence, therefore, theoretically, decrease the symptoms of ADHD if they're adhering to the treatment plan, increase executive functioning, increase their capability, and increase treatment plan success and minimize their ADHD symptoms long term. So in conclusion, I think it's a really important factor to consider adult females with ADHD and their capability of change due to the impact of ADHD on their executive dysfunction. A clinical tool should be established to help identify the client's capability and barriers to behavioural change. And I really feel as though this could assist to increase treatment plan adherence and assist with health priorities.